Hello and welcome to Lesson 4, Medications to Treat Cardiovascular Disorders. Our objectives are outlined here, and again, as we have spoken about in class, our focus is on pharmacotherapeutic properties of drugs and application of those drugs to cases. Our medications are listed here in alphabetical order. This first video will only cover antihypertensive medications. So hypertension is our first topic, and we don't treat hypertension just to get their numbers down and make it look pretty. We treat it because hypertension has the capacity to damage a lot of organs in our body. We know that hypertension is one of the leading causes of death and mortality and morbidity worldwide. Our end organs include the brain, where stroke and transient ischemic attacks can occur because of hypertension. The heart, where damage can cause left ventricular hypertrophy, cardiac disease, coronary artery disease, and heart failure. The eyes, where hypertension can cause retinopathy. The peripheral vascular system, where there is atherosclerosis and arterial sclerosis. And similarly in the kidney, where because of the vascular changes secondary to hypertension, we can get renal failure. We're going to focus now on the 2017 guidelines for prevention, detection, evaluation, and management of high blood pressure. And this is kind of the current thinking. You will hear folks talk out there in clinicals about JNC 7 and 8, which preceded this set of guidelines. So there are some variations out there, and folks may be talking about older guidelines. There aren't a lot of huge changes, but this guideline does have a few nuances that I'm going to introduce you to, and then we'll talk mostly about the medications. So first of all, just to remind ourselves about what blood pressure and elevated blood pressure means. And again, if you are familiar with JNC 8 guidelines, the stages were not included there, but they have been added back into this new guideline. And we see that basically, as we have always learned, normal blood pressure is less than or equal to 120/80. And then as we move up, we consider the stages of hypertension. One of the things that's important to understand when you're considering drug therapy is at what point do you decide to start a medication to treat hypertension? So, you know, again, the guidelines have gone back and forth, and we have two columns here. First, the column here of the blood pressure threshold. And this is the point at which, as a clinician, you're going to decide, once they reach this area, I think I should probably get into either medications or, in the case of these comorbidities, more likely it's going to be additional medications. And I'm going to skip over the elders for just a minute, but talk about this differential here. So we're looking at folks who and we're going to talk about in a minute how to calculate their 10-year ASCVD risk, but someone who's at higher risk for cardiac events in life, we are going to enter the algorithm and start treating them with drugs when their blood pressure is consistently over 130/80. In the case of folks who have a lower risk, who are not really, you know, in that risk pool, we're going to say over 140, over 90 is when we're going to kind of trip the trigger. In all cases, however, we're looking at the goal of 130/80 all the way through, everybody's goal. Now, the one exception to the diastolic pressure being included is in elders. And regardless of where they live, elders, because of physiology, as they age, their diastolic pressure may actually decrease. And we don't worry as much. And it has, and when you look at the evidence, really treating their systolic blood pressure to goal is much more effective in terms of prevention of death from hypertension causes. Now, again, these are older persons. They're talking about living in the community, because what they're saying here is basically if a person is very frail elder, they're institutionalized, really with so many comorbidities, that we may be a little more generous, if you will, with their blood pressure readings, because of course giving antihypertensives can lead to dizziness, especially in elders. This is very bad in terms of fall risk. So we're not as strict, if you will, as people age, and that kind of makes sense. All right, so this is kind of our little punch list of how we approach a person in terms of hypertension. It's a fairly long list. Some of it is self-evident in terms of talking about goals and so forth. We're going to talk a little bit about a few of these and focus on medication therapy. We're not going to really get into some of the more fine details. That's for another semester. So again, just a quick brush over if you are familiar with JNC 8 versus the 17 guidelines. First of all, they do ask us to look at the ASCVD risk calculation. There is an app that you can use for that. We're going to get into that a little bit later. Age considerations are now kind of a judgment call versus in JNC 8, you actually saw that those over 60, we tolerated a goal of 140 over 80 instead of 130 over 80. And so that goal has changed again back to the 130. We still consider the racial heritage. That is new since JNC 7. The fact that ACEs and ARBs, which we'll talk about later, aren't necessarily as useful in Black populations. We're back to stages, which in JNC 8 there were no stages. And back in JNC 7 there were these things called compelling indications, but since JNC 8 we have used chronic kidney disease versus non, and diabetics versus non-diabetics. So those are high-risk areas that we do take a look at different therapies, and of course, again, they flow into the cardiovascular risk. You're going to hear me say this many times this semester, but diabetes is a cardiovascular disease. So beta blockers, I just want to make a note, you see a lot of patients, especially elders, on beta blockers. They're low on the decision tree in terms of hypertension, unless the person has stable ischemic heart disease or heart disease in general. You will see a lot of patients on it for those reasons. And yes, it lowers their blood pressure, but that's not the primary reason they're on the medication. So it can be confusing, and patients often think they're on it for blood pressure. So this is kind of the algorithm. Please note that in the boxes, the class that they're referring to is not regarding the drugs. It has to do with the evidence that supports the data that you see here. And so it just reiterates what we've already said, that we are going to treat patients whose blood pressures are above the threshold in certain groups of patients, and then we're going to continue therapy. And I'm going to just skip over this, although it's a good thing to keep in a back pocket. So our initial medications that we like to choose for antihypertensives are going to be thiazide diuretics, calcium channel blockers, and ACE inhibitors, or angiotensin renin blockers, or ARBs. Please note down below that there is the harm notice that use of ACE inhibitors together with ARBs or renin inhibitors are potentially harmful, and do not do that. Do not combine those two drugs. I'm going to go back up to the upper box to just note that in terms of thiazide diuretics, chlorthalidone, which is a fairly old drug, but it has much more efficacy in terms of being the preferred thiazide diuretic. We'll talk later about the fact that this is not as commonly used, as the pricing is a little bit higher, about 4 times higher than the cheapest thiazide diuretic, hydrochlorothiazide. So the other thing that students always ask me is, should I start one drug at a time or should I start two? And because there are many combination drugs out there, usually combined, we often have ACEs combined with a thiazide diuretic, and those are used by many. The recommendation is to go ahead with two agents. I will just make one little caveat to this, and that is that sometimes if you are able to see a patient in close follow-up and monitor their response to medications, it's reasonable to me to start one drug and then fairly quickly add the second drug, and of course checking their blood pressure and seeing if they're at target yet. Folks who are in stage 2 hypertension almost always need two agents, is what this is saying. The reason I like to be a little bit cautious is that, especially with people on limited incomes, if we have two drugs given together and the person has some kind of drug reaction, I'm never sure whether it's one drug or the other. So I like to see them separated just for a while until I'm sure they're both okay. And then, of course, it is easier for a patient to take a combination drug because they don't have to remember two different drugs, to take two different drugs. So the other thing that's important that I already mentioned is that for Black adults with hypertension but without heart failure or chronic kidney disease, including those with diabetes, the initial antihypertensive should include the thiazide diuretic or calcium channel blocker because that has better effect. And in Blacks, we'll often see a lot more stage 2 hypertension or above, and that we're just going to need two drugs is the comment. The reason on the first comment about the diabetes is in some guidelines, older guidelines, you will see that for diabetes we really want people on ACE inhibitors because they have some renal protection early before chronic kidney disease starts. You'll see that going back and forth between guidelines. So we're going to go right into a case. This is our friend Joe, and he is a 49-year-old. He is Caucasian, had a PE physical exam, that is, 15 years ago. At that time, his blood pressure was elevated. At this time, his blood pressure is elevated. He has a range of 140 to 160 over 85 to 90. He has a history in the past of being told he had borderline high blood pressure when he was in the service. He also has some osteoarthritis. He had a herniorrhaphy at age 30. His family history is positive for cardiovascular disease pretty strongly. He also is a smoker of 50-pack year history. Smokes 2 packs per day now. He drinks 4 to 5 beers every evening and denies street drugs. He works full-time as a mechanic, lives with his wife and 2 teenage sons. He is currently on extra strength buffered aspirin as needed for joint pain, once a day men's multivitamin, over-the-counter Pepcid, and here are his vital signs again today. He has no signs of secondary organ damage here, which is great. We're catching him before any end organ damage has apparently occurred, because we can see that his fundus are clear and that he does not have the S3 or S4.